Hello, hello. This is Dr. Shamama Tuzara, and today my topic of presentation would be renal hemangioblastoma. It is one of my topic which I presented during my pathology observership this year in the month of May at Mount Sinai Main Hospital, and it's a new entity and a great topic. So I request everyone to be attentive and just grab your notepads and pens or whatever you want to note stuff, and let's just dive into the topic. And I hope you guys will enjoy it. It's an interesting topic. So let's get started. So, first of all, we'll talk about hemangioblastomas overall, and then we will dig deeper into the main topic, which is the renal hemangioblastomas. So, starting, hemangioblastomas they mainly occur within the central nervous system. Okay, so it starts within the central nervous system. It's mostly in the cerebellum, in the brainstem, and medulla oblongata. Mostly it occurs sporadically, while approximately 20 to 25% of the cases they are associated with the VHL disease, which is von Hippel-Lindau disease. It's an autosomal dominant inherited disorder with germline mutation in the VHL gene on chromosome 3p25. It can also occur outside the central nervous system in the soft tissues, peripheral nerves, bones, skin, within the GIT tract, in the urinary tract, including bladder and also in the adrenal gland. So this is its wide presentation. Today we'll discuss more in detail the sporadic renal hemangioblastoma. It's basically a rare extracentral nervous system tumor, and it's typically not linked with the VHL syndrome. In 2016, WHO classification of tumors categorized it as a renal hemangioblastoma as a mesenchymal tumor of the kidney for the first time. And the first case was reported by Nonaka et al. In 2007. So that was first time it was diagnosed. And till now, just 40 cases have been reported in literature that shows that it's a rare entity, and still studies are being done on it and on how it occurs, its evolution of all the findings and all. So till now, the studies, the data which we have will be discussed in this presentation. So, how it would present? It basically is asymptomatic, and it's incidentally presented or diagnosed as a renal mass as seen on imaging, and that's basically shown in this image, which shows like this is a normal kidney highlighted by my pointer, and this is the kidney with this mass, this well circumscribed round mass, that's the tumor. This is how it's incidentally diagnosed. And some cases are reported in which patients do have some symptoms, like they have hematuria, osteophyalgia, which is pain in the lower back and in the loins region, and they would have fever, weight loss, secondary polycythemias, and but mostly it's asymptomatic, and no family history or clinical evidence of VHL syndromes was noted in these cases. Renal hemangioblastoma is predominantly seen in adults, with just a single case reported in a 16-year-old adolescent female. With the reference I mentioned here, this is the PMI ID of it. A slight male predominance is seen, but it's not that much, so can be ignored. So, talking about the gross findings, now I I actually know all the pathology viewers, they would be thinking that, hey, just fast forward this whole presentation findings and let's start with the pathology stuff. We are sitting on the scope and we need to see how it looks grossly and microscopically and see whether what we are seeing is actually the entirety or not. So, yes. Completely agreed. So let's jump on the gross findings. So grossly, it basically looks like a well circumscribed solid tumor with a thick fibrous capsule surrounding it. And only just two cases reported have been seen with areas in which the tumor shows poorly marginated growth, and it just breaks from the fibrous capsule which surrounds it and extends to the outside of the capsule. So that's just reported in few cases, two of those. In rough size, it's like 1.2 centimeter to 15 centimeter in diameter. And when we cut it on the cut surface, it shows it's a grayish white, grayish yellow, or grayish brown, or red brown to gray yellow in color, the tumor, with sometimes incidentally foci of hemorrhage and necrosis are seen incidentally. Moving on, these are the gross findings. So it's exactly showing like this is that tumor, this well circumscribed tumor. We can see it's grayish brown. I'm sorry, excuse me. The grayish brown tumor with this appearance here. Further, if you see here, it looks like this is the whole tumor grossly seen here. So just some couple of findings from a research article. I've mentioned the reference down, and this is further just cutting the tumor in detail and showing you the cross-section area of it, that how it would look within it like these. This is the whole tumor. Moving on to the microscopic findings, the most favorite part of us, how it would look in the microscope, and there the interesting part starts. So how it would look is, as I mentioned, it has this capsule clear boundary. So microscopically, it would also have a clear boundary between the tumor and the surrounding tissue, with a thick fibrous capsule seen. And as we can see in this image, this is basically the tumor. This is the thick fibrous capsule. This line showing the edge of the capsule, and shows that it is confined within the capsule, and there is a boundary between tumor and the surrounding tissue. Secondly, on low magnification, the tumor cells would arrange like this in the image, in nest or in sheets of cells. And if you just zoom this in, it would look like, see these red areas surrounding the sheets of cells. These are basically the capillary networks. Which is like hemangioblastoma from the name it tells. It would have like this thin wall capillary network surrounding these sheets of cells. And in some regions, like in this picture it's shown, they would be like interstitial edema and with some tumor cells with it, and thick walled dilated blood vessels would be seen as shown in this image. This is the whole thickness of the blood vessel. Apparently looks very dilated. It can present like this, and on higher magnification, like zoom in, zooming in, it will show like these cells, like so. See, very oval shaped, polygonal. They don't have like single shape, there are multiple shapes, see, polygonal shapes. And some have this bright pink cytoplasm, some have this pale cytoplasm, while some have these clear cytoplasm with, if you can see these vacuolar areas, this bubbly appearance. It looks like that is filled with the lipid vacuoles within the cytoplasm. So this is how the cell would look on higher magnification, like zoom in. So further, the nuclear features, nuclei would be, if we see here in this image, this D image, see, these are like small, round nuclei. They show mild atypia, but it's not like very significant atypia seen here. And mitotic figures are like very scarce in this case, as shown in both the images. Moving on, the stroma, it would show lymphocytic infiltration, like of course lymphocytes, the blue cells would be, trickling everywhere, and the yellow-brown pigment. If this is, if you guys when you watch it, you just zoom it in, and then you can see that here there is like this yellow-brown pigment, which is the hemosiderin deposition. And no tumor necrosis or any hemorrhage is seen in this case, which is taken from the site I've already mentioned reference in the previous slide. It would also show this, see, this pink, nice hyaline stromal cell degeneration. So this is also seen in some cases called stromal cell hyaline degeneration, this pinkish material seen in this image. And some cells, there in some cases, a Samoma-like calcification. So this is like going through med school. This is one of like, our favorite finding that, yay, if we can't diagnose anything, we can see the Samoma bodies. And many of us are like make mnemonics in which these are seen. So these bright purple areas, these are basically the Samoa-like calcification seen in some cases of renal hemangioblastoma. And in some, we do see like eosinophilic hyaline globules in some of the tumor cells. And if you look in this image, you see like these pink areas, these pink areas. These are like the hyaline globules within the cells, and this is how it presents. These are just the, a summary of all the images I already shown you before. So this is the whole summary. So, moving forward, talking about the IHC findings of this case. So, IHC is now important nowadays. Like, of course, after the gross findings, the microscopic findings, we need IHCs to narrow down our diagnosis and to rule in and rule out what we are doing in the process of diagnosis. So, starting, which are positive in it. So, four important stains need to be remembered here: Vimentin, S100, alpha inhibin, and neuron specific enolase. They show strong positivity here in this tumor, and out of these, S100, alpha inhibin, and neuron specific enolase, these later three, they have strongly, they are sensitive for renal hemangioblastoma, but this specificity is like unsatisfactory, but still they help in ruling out. And AE1, AE3 is positive, EMA, CD10, PAX8, they are shown to be positive, and as the name suggests, it's renal hemangioblastoma. So hemangio means a lot of blood vessels, and that's why there would be an abundant capillary network, as I showed before in the microscopic findings. So that would be highlighted by CD31 and CD34. And the negative stains are CK7, desmin, smooth mucilectin, and HMB45, melon A, synaptophysin, chromogranin, CD56, and brachyury. It's positive in serous hemangioblastomas, but it's not positive in the extracranial tumors, and that is how they are differentiated between each other. Uh, the IHC images, alpha inhibin, as I told, these all four are strongly positive here, and this is how alpha inhibin would look. Strong positivity in the tumor cells. This is S100, again positive. Paxil8 showing this nuclear positivity here, and this is, look how beautiful it is. This is CD34. As I mentioned, vessels, so the endothelial cells are basically highlighted by CD34. That's why, see, it's giving a good reticular network, like a net of, sheet of net is placed here. So beautiful image, confirming a lot of capillary network surrounding the tumor cells. Uh, Moving on, this is CD10, which is strongly positive, and here is the neuron-specific enolase showing positivity here in the tumor. Uh, and these are basically the recent molecular genetic studies. I will discuss here from the studies shown recently. That's a 2025 study performed. What a summary of that whole study was that PCR analysis was done of VHL exons in 9 studies on 14 patients. Second, loss of heterozygosity testing was done of chromosome 3p in 2 studies and in 5 patients. Fish testing was done for chromosome 3p deletion in 2 studies on 3 patients, and NGS studies was done in 2 studies and on 11 patients, and that's the next generation sequencing. And the reference of the study from which I'm telling you this whole molecular genetic studies is mentioned below. Now I'll discuss the results of it. So what were the results of the study? So we didn't find any VHL gene mutation, no chromosome 3p deletion was seen, and no loss of heterozygosity was detected in any of the 25 tumors, plus the 3 tumors which were additionally discussed in that study at that time. However, pathogenic TSC1, which are the tuberculosis complex gene mutations, they were observed. Okay. And moving on, one other study which was done by Wang et al. In 2024. Now, this study took 10 renal hemangioblastoma cases, and they were analyzed by NGS, while 5 CNS hemangioblastomas were used as control to compare the findings of both. And what they did was the GPNB and MB, excuse me, that's glycoprotein non-metastatic BIHC was performed on both the groups, and here is the reference of the study. Now, what were the results of this study? So the GPNB that was strong and diffuse positive in all the renal hemangioblastoma cases, while it was completely negative in the CNS hemangioblastoma cases, a good difference between both. And in addition, renal hemangioblastoma cases, 5 were shown to be positive for TSC1, three showed positivity for TSC2, and two also showed positivity for mTOR mutations. And GPNB was, of course, strong and diffuse positive in all renal hemangioblastoma cases, and VHL was a negative in all the cases. Moving on, while comparing it with the CNS hemangioblastoma cases, all five cases with VHL mutations, and they showed VHL mutations in CNS1. No TSC and mTOR involvement was seen, which was seen positive in renal hemangioblastoma, and GPNB was completely negative in all, which was completely positive in all in the renal hemangioblastoma. So I guess now you would have a good transition in your mind that how the mutation at mutational level both are differentiated from each other, and this is the reference of the study I'm talking about, and little bit on how the pathogenesis occurs in the TSC complex. Just a little bit, I'll give you a brief insight on how it works. So, first of all, we talk about the normal function because it's important to understand the normal in order to understand what is disrupted and then what causes the subsequent pathway mutations. So, we'll start with what's normal. That is like, so TSC1 gene that combined with TSC2 and TBC1D7, and it forms a protein complex. Okay, that complex then inhibits the REB, which is an enzyme. It's a GTPase enzyme, and after inhibition of the REB, it then suppress the mTOR C1 activity, and this is actually required, and this suppression then leads to the normal regulation of the cell growth and its proliferation. Now, the interesting part, what happens if there is mutation in TSC1 or TSC2, which we previously seen that it is seen in, excuse me, it is seen in this renal hemangioblastoma. So, a disruption of TSC1 and TSC2 complex, when there is mutation in the complex, that lead to disruption of this complex, which told before, and when that complex is disrupted, its function was to inhibit REB, and now it would not inhibit REB because of its own function loss, and as a result, REB would be overactive. Once it's overactive, that leads to continuous activation of mTOR C1 because if it has been inhibited, it would have suppressed its activity. So mTOR C1 would be very active, and as a result, uncontrolled cell growth and proliferation would occur, and that lead to the development of tumors, which lead to the whole complex presentation of TSC, the tuberous sclerosis complex. So, just a brief summary again. Whenever there is mutation in TSC1 and TSC2, the complex gets disrupted. That leads to loss of its normal function, which is REB inhibition. If it's not inhibited, then it's overactive. And once it's overactive, that causes continuous activation of the mTOR C1, and as a result, cell goes undergo, uncontrolled growth, uncontrolled proliferation, and lead to development of tumors. And this is the presentation. Moving on, there's another pathway which is PIK3CA or AKT pathway. What this pathway does, it directly or indirectly activates the mTOR, the end product, and as a result, the GTP binding state of REB by inactivating the TSC, and it then enhances the mTOR activation. That leads to again the uncontrolled cell growth, proliferation, and development of tumors. And it is found in few cases of renal hemangioblastomas. I just briefly discussed the pathogenesis at molecular level of how the development of renal hemangioblastoma occurs. And thank you so much for bearing with me, and I hope you guys, understood few of the good points, and that maybe help you when you would be sitting on the scope and solving this case, or maybe preparing for your board exams if there's prompts up there. And I would like to, special thanks to my mentor, Dr. Joe. He was my mentor when I was doing my pathology observership at Mount Sinai Main Hospital, and he gave me this opportunity to present in a meeting there, and it was a great learning opportunity. And this is one of a cute memory from that day. It was actually my last day of rotation when I presented, and I just took this picture and it was like, "Hey, just keep it." I was like, "I'll keep it as a memory of ours." So yeah. Thank you so much once again, and I hope you guys liked it. And if you liked it, please share your feedback in the comment section. And if any of the seniors is watching me out, if I said something wrong, feel free to correct me, and I would really appreciate that. And any feedback regarding my presentation too, I would really like that. So yeah, thank you. uh, I'll come up with the next video. Just a brief thing. The next would be actually on the group of tumors with a TSC mTOR pathway mutations, and they are actually the some word differentials of this entity. So I would suggest that after watching this video, go look for that video and get a better understanding of the differential diagnosis. And yeah, see you guys in the next video. Bye bye. Take care.